Hola, buenas tardes. ¿Me escuchan? Hola, no lo escucho. Ahí me escuchan. Es que necesito saber porque y me tengo que empezar porque tenemos una reunión internacional ahorita a las 2.
Sí, Sarita, se escucha perfecto.
Perfecto. Y allá en el sexto piso se escucha. Hola, ¿me escuchan? O sea, lo acabo de apagar porque hablé ahorita. Ya me están escuchando ahorita. Hola, ya, ok. Listo, entonces voy a compartir pantalla. Por fin me avisan si se está viendo bien la pantalla.
Acá lo estoy viendo bien, Sarita.
Gracias, doctora. En la Clínica Colombia, en el sexto piso, ¿alguien me puede confirmar?
Danos un momento, Saris, que estamos teniendo un problema aquí técnico.
Ok, me avisan para empezar.
Sari, ya puedes empezar.
Listo, perfecto. Se ve la presentación bien.
Aló, ¿me oyes?
Hola, sí.
¿Sí? ¿Me estás oyendo? Pues ahí está conectado.
¿Me escuchan?
Sí, aló, Sarita.
Hola.
Sara,
Sí, ahí se escucha.
Ah, bueno, perfecto, listo.
Sara, ¿me oyes?
Sí, doctor, aquí estoy.
Creo que en la Colombia no te oyen, Sari, pero nosotros sí te oímos.
Listo. Le voy a escribir.
Estamos, qué tal estamos? ¿Sí me estás oyendo?
Sí,
Sí, doctor,
doctor,
lo
sí te
estoy
estamos
oyendo.
oyendo.
Me oye entrecortado. Sarita, pues,
Hola.
bueno, tenemos un poquito de problema aquí para conectar la pantalla del salón, pero tenemos que empezar, así es que la información va a estar dada solamente por las conexiones que ustedes tengan en sus teléfonos. Cuando tengamos más, cuando ya estemos en contacto, les avisamos. Bienvenidos, esta es una charla de mamografía con contraste que nos va a servir mucho y después viene la doctora Lund con vibras por ultrasonido a las 2 de la tarde. Continúa, Sarita, por favor, a las 2 termina, gracias.
Listo. ¿Cómo están todos? Buenas tardes. Te confirmo por última vez, me están escuchando, ¿sí?
Sí, se escucha.
Ah, bueno, perfecto, listo. Entonces, yo soy Sara Gómez Milanés, soy residente de cuarto año de radiología aquí en la Universidad SANITAS y el día de hoy vamos a hablar de la mamografía con medio de contraste o como sus siglas en inglés dicen, Contrast Enhanced Spectral Mammography, como tenemos ahí en la presentación, CESM. Dentro de los objetivos de la charla vamos a tener que la mamografía con contraste, vamos a ubicarla como una herramienta de imagen que además de ser innovadora, tiene amplias ventajas respecto a, pues en su comparación con las indicaciones tradicionales de la resonancia magnética. También vamos a hablar de las normativas que se rigen internacionalmente para garantizar la buena ejecución técnica de este estudio radiológico. Vamos a determinar el valor predictivo positivo y las limitaciones que puede tener la mamografía con contraste en nuestro entorno y vamos a hablar también del protocolo que utilizamos en nuestra institución, pues tuvo su actualización y vamos a detallar las competencias del equipo, tanto humano para la adquisición de todas estas imágenes, como de la lectura como radiólogos de estas imágenes. Entonces tenemos que tener en cuenta que esta Contrast Enhanced Spectral Mammography o mamografía con contraste es una técnica pues avanzada de imagen que va a combinar la clásica mamografía digital que hemos venido usando todos estos tiempos, que es la convencional, con la administración de un medio de contraste que va a ser yodado, similar al que usamos en las tomografías. Su funcionamiento se basa como tal en la angiogénesis. Entonces, los tumores malignos suelen crear, como sabemos, nuevos vasos sanguíneos que van a usar para alimentarse y crecer, y estos vasos son más permeables, permitiendo que el medio de contraste se acumule y que nos realce al inyectar medio de contraste. Tenemos que tener en cuenta que el equipo como tal realiza pues es un equipo de energía dual o de doble energía, va a realizar 2 disparos rápidos por cada compresión. Cuando hablamos de baja energía, estamos hablando de que pues, la imagen que va a proporcionar es pues, una imagen similar, una imagen de mamografía digital estándar, o también tenemos posteriormente una imagen de alta energía que al combinarse con esta imagen anterior de mamografía digital estándar, mediante un software, va a restar como tal el tejido como la densidad del tejido de la mama y va a realzar la zona donde esté captando el medio de contraste. Es importante tener en cuenta que la sensibilidad de este estudio va del 96 al 98,9%, es decir, es bastante alta, una especificidad un poco más baja, sin embargo significativa, que va del 76 al 80%. Y también tenemos que tener en cuenta que suele tener menos falsos positivos que la resonancia magnética. En cuanto a sus indicaciones y contraindicaciones, tenemos que dentro de las indicaciones está pacientes que tengan diagnóstico de una enfermedad, un cáncer de mama o una enfermedad recientemente diagnosticada de mama, que no esté indicada la realización de resonancia magnética, el control o el manejo el control de la neoadyuvancia, de la respuesta a la neoadyuvancia o el tratamiento con quimioterapia, y ciertas resoluciones, o sea, para resolver conflictos que haya entre otras modalidades de imágenes, ya sea en mamografías o ultrasonido. Hay que tener en cuenta en este punto que pues en mujeres que han sido intervenidas quirúrgicamente en múltiples ocasiones o que han presentado biopsias o con pacientes que tengan múltiples microcalcificaciones que sean de difícil caracterización, en la mamografía convencional está indicado para tamizar de pacientes que estén en alto riesgo, riesgo intermedio o como tal lesiones que ya, o seguimiento de lesiones que sean de alto o de riesgo intermedio. Es una alternativa también para la resonancia magnética en pacientes que la tengan contraindicada, como decíamos antes, que tengan claustrofobia, o sea, usuarios de marcapasos, que presenten obesidad, una mama tratada con procedimientos quirúrgicos previos y en mayor relevancia en pacientes que tengan cirugías que sean conservadoras en procesos no formativos, en pacientes que presenten telorragia y en mamas que sean muy densas también es una buena opción y está indicado. Mientras que las contraindicaciones van a ser que tengan reacción severas al medio de contraste, que lo hablaremos también durante la charla, que pacientes que tengan insuficiencia renal por la administración del medio de contraste, cuya tasa de filtración glomerular sea menor a 30, que estén en embarazo o en lactancia, que esa es una contraindicación relativa, en este caso toca sobrepesar el riesgo-beneficio, o que estén presentando actualmente procesos inflamatorios agudos o crónicos. Entonces, dentro de los usuarios del protocolo, o sea, las personas que vamos a ser partícipes de la realización de este protocolo, vamos a ser los radiólogos, están las jefes de enfermería, tecnólogos y auxiliares de enfermería. Es importante saber qué va a hacer cada una de estas personas y por qué son importantes durante el proceso para lograr tener un adecuado estudio, tanto técnico como en la calidad y en la atención del paciente. En cuanto a nosotros como radiólogos, nuestra labor va a ser realizar la planeación del procedimiento, explicar el procedimiento a la paciente, realizar la firma del consentimiento informado y explicarle, asistir al procedimiento, es decir, estar en el procedimiento cuando se requiera o desde la estación de lectura para estar pendientes de los pacientes, realizar la lectura del estudio y también liderar como tal todo el equipo y las maniobras de soporte vital básico y avanzado en caso de que haya reacciones adversas al medio de contraste. En cuanto a los jefes de enfermería, ellos tienen que estar pendientes de verificar el adecuado agendamiento del paciente, el ingreso al RIS, confirmar el código de procesamiento, verificar la firma del consentimiento informado, verificar que se hayan tomado los laboratorios, creatinina, y calcular la tasa de filtración glomerular, canalizar al paciente y calcular la dosis del medio de contraste, que van a ser aproximadamente 1.5 centímetros cúbicos por kilogramo, y verificar el carro de paro que esté completo y asistir las maniobras de soporte vital básico que van a ser lideradas por el radiólogo en dado caso que el paciente presente reacciones adversas al medio de contraste. En cuanto al auxiliar de enfermería, verificar también la firma del consentimiento informado, súper importante, confirmar la dosis del medio de contraste y verificar la permeabilidad de la vena canalizada, cargar la dosis de medio del contraste en el inyector, administrar el bolo de solución salina una vez finalizado el estudio y pasar al paciente y monitorizarlo en la sala de recuperación. En cuanto a los tecnólogos, es importantísimo verificar el adecuado agendamiento del paciente también, el ingreso al RIS, también verificar que sea el paciente del que estemos hablando y revisar los estudios previos para confirmar o sea, que si la paciente ya dispone de un estudio como tomosíntesis y en caso de que no, informar al radiólogo si desea proyecciones específicas o el estudio completo. Hay un tecnólogo número 1, un tecnólogo número 2. En cuanto al tecnólogo número 1, se debe encargar del conteo, de verificar el tiempo exacto de las adquisiciones, de la inyección, de iniciar la inyección de medio de contraste y controlar que finalice la misma, informar al tecnólogo número 2 para que inicie el posicionamiento y la adquisición de la primera proyección a los 2 minutos de realizar la inyección del medio de contraste, mientras que el tecnólogo número 2 debe verificar el posicionamiento y la compresión de la mama de acuerdo al protocolo y según el aviso pues, del tecnólogo 1 que dijimos previamente. Ahora, la mamografía espectral o energía dual con medio de contraste es importante que son, como decíamos al principio, 2 imágenes consecutivas por proyección y evaluamos ambas mamas en 2 proyecciones. Las placas tardías son a los 7 minutos y se hace también una proyección lateral tardía de la siguiente manera. Se inyecta el medio de contraste, si iniciamos la adquisición a los 2 minutos de inyectar el medio de contraste, y la primera imagen que vamos a obtener va a ser una medio lateral oblicua de la mama enferma, después una cráneo caudal de la mama enferma, posterior una cráneo caudal del lado no enfermo, una medio lateral oblicua del lado no enfermo, y se va a realizar una proyección lateral tardía verdadera a los 7 minutos. En dado caso que el realce a los 7 minutos sea muy tenue, se considera realizar una nueva adquisición a los 10 minutos. Y en dado caso van a estar los tecnólogos pendientes de realizar proyecciones adicionales, teniendo en cuenta pues el modo de mamografía digital simple o el modo de adquisición con medio de contraste. Esto es lo mismo que acabamos de mencionar. Entonces, siempre tener en cuenta primero la medio lateral oblicua de mama enferma, que es la primera adquisición, lo que acabamos de mencionar anteriormente. Acá tenemos un ejemplo rápido, ya vamos a ver otros ejemplos de una mamografía digital convencional. Vemos una mama densa en la que no podemos distinguir, pues no podemos distinguir bien como tal si hay una lesión tipo no masa, ahí, que, como podemos ver a continuación. Sin embargo, cuando se realizó la mamografía con contraste, vemos que hay una lesión tipo no masa, una simetría en el cuadrante superior, en el cuadrante superior de la mama derecha. Listo. En cuanto a la descripción como tal del procedimiento, entonces, ¿qué tenemos que tener en cuenta como radiólogos? Tenemos que verificar las imágenes previas del paciente, tenemos que tener una mamografía o verla también la mamografía en 2D, la normal. La tomosíntesis solamente si el paciente no dispone, como decíamos previamente, de una tomosíntesis. Imágenes recombinadas posteriores a la administración de medio de contraste. Durante el momento de la realización no es necesario como un momento específico del ciclo menstrual de la paciente. Eso es importante tenerlo en cuenta porque lo preguntan muy seguidamente. El tiempo de adquisición son máximo 10 minutos posterior al medio de contraste. Y las imágenes de baja energía van con el kilovoltaje de 28 a 32 y las recombinadas van con un kilovoltaje mayor a 32. En cuanto al medio de contraste, usamos medio de contraste yodado no iónico, ultravis 300 miligramos por decilitro, tenemos las presentaciones de 50 y de 100 mililitros. La dosis máxima en el inyector van a ser 190 mililitros y la tasa de inyección 2.5 mililitros por segundo. Y la dosis que ya la habíamos comentado previamente. Dentro de las limitaciones técnicas está la evaluación de las masas posteriores o invasión de la pared torácica, evaluación subóptima de las adenopatías, que no va a ser la indicada en estos casos, falsos negativos en microcalcificaciones malignas sin masas que no estén subyacentes, por lo que pues las calcificaciones no van a realzar con medio de contraste si no tienen la masa subyacente, falsos negativos en cánceres de bajo grado o pequeños que tengan realce mínimo o lavado muy rápido, falsos positivos que en caso de tener lesiones benignas hipervasculares, no va a lograr como tal una curva cinética que la podemos valorar en la resonancia magnética. La radiación va a ser un 20 al 54% mayor que una proyección rutinaria en una mamografía digital y que la paciente presente implantes de siliconas. Ya cuando vayamos a documentar los resultados, este es el orden que tenemos que llevar para hacer el informe. Entonces, lo primero es la indicación del estudio, la comparación con los estudios previos y antecedentes relevantes del paciente, la técnica que vamos a utilizar para describirla. También tenemos que mencionar la densidad mamaria y el realce del parénquima de fondo, o sea, el BPE, la descripción clara de cualquier hallazgo importante, la conclusión, la valoración BIRATS, posteriormente el manejo de las sugerencias y la categoría BIRATS. Dentro de los descriptores BIRATS para la mamografía con contraste, tenemos los siguientes. Entonces, en cuanto al tejido mamario, tenemos que mencionar la composición de la mama, si es A, B, C o D. A, casi pues enteramente grasa. B, áreas dispersas o heterogéneas donde haya densidad fibroglandular. C, heterogéneamente densa. Y D, ya es homogéneamente densa o extremadamente densa. El realce parenquimatoso de fondo, el BPE, aquí lo vamos a describir como mínimo, leve, moderado y marcado. Mientras que la simetría, pues, de decir si es simétrico o si tenemos alguna asimetría. Hallazgos en las imágenes de baja energía, es decir, referirse estrictamente al léxico que conocemos ya en el BIRADS de mamografía estándar. Los hallazgos en imágenes recombinadas, entonces, en cuanto a los nódulos o masas descriptores, la forma ovalada, redondeada, irregular o lobulada, que es uno de los nuevos descriptores, los márgenes, si están circunscritos o no circunscritos, también se habla de márgenes, ahora se habla de márgenes indefinidos, que va a reemplazar la palabra que antes se usaba de irregular o microlobulado, que ya no se usan, y otro de los descriptores es márgenes espiculados. Y el realce interno de la lesión va a ser homogéneo, heterogéneo o un realce en anillo. En cuanto a los realces no masas, ya no se utilizan múltiples regiones, eso fue eliminado, sino que la distribución se habla de focal, si el realce es lineal, segmentario, regional o difuso. El realce interno puede ser homogéneo, heterogéneo o agrupado. Y en cuanto a la simetría del realce como tal, también hablamos si es homogéneo o es heterogéneo en su porción interna. En cuanto a la intensidad del realce, del hallazgo, o sea, si es realce nodular o no nodular y la visibilidad, tenemos que decir si esa visibilidad o el realce es leve, moderado o severo. Es muy importante, el cual no debe faltar siempre en un informe radiológico que estemos elaborando. Dentro de los hallazgos en imágenes de baja energía con realce asociado a imágenes recombinadas, tenemos que describir la morfología con el mismo léxico de la mamografía, el patrón del realce interno, ya lo mencionamos, la extensión del realce, que esto es muy importante, que si es realce parcial, si es realce homogéneo, si el realce se extiende más allá de la lesión o el realce del parénquima adyacente está presente o no, y la intensidad del realce del hallazgo como tal, ya sea realce nodular o no nodular, ya sea leve, moderado o severo. Los hallazgos asociados que también debemos escribir y no olvidar es si tiene, pues ver el pezón siempre, si hay hallazgos de retracción al pezón o si en los estudios previos ya es una persona con un antecedente de pezón invertido, si tiene compromiso del pezón, retracción cutánea, engrosamiento cutáneo, compromiso cutáneo o adenopatías axilares visibles. Entonces, en cuanto al BIRADS, teniendo en cuenta lo que acabamos de mencionar, el 0 siempre se va a seguir refiriendo a una categoría que es incompleta y vamos a necesitar imágenes adicionales de comparación o proyecciones adicionales o técnicas adicionales. Los hallazgos que estamos viendo en estas imágenes no se observan en imágenes de baja energía, lo cual no puede ser totalmente caracterizado y va a requerir de otro estudio complementario. En el BIRADS 1 es un examen normal, es un hallazgo negativo, los realces son, no hay realces anómalos. El BIRADS 2 estamos encontrando una probabilidad de malignidad del 0%, es decir, es completamente benigno. Dentro de los hallazgos de baja energía van a ser los mismos criterios de la mamografía estándar, como ganglios intramamarios, implantes y calcificaciones, ya sean vasculares, cutáneas, gruesas o layering, que son pues, la leche cálcica con nivel, que tengan masas de contenido graso. Los hallazgos visibles en las imágenes recombinadas, entonces tenemos que, o sea, que son benignos, va a ser el realce parenquimatoso de fondo, ya sea simétrico, mínimo, leve, moderado o marcado, teniendo en cuenta que focos dispersos se engloba mejor aquí, o como el realce del parénquima como tal punteado, ya que foco se eliminó del léxico principal. También que sean quistes o masas bien circunscritas que no realzan, como quistes oleosos, seromas antiguos, cicatrices posquirúrgicas estables que no presenten realce. En cuanto al BIRADS 3, es un hallazgo, como sabemos, probablemente benigno, que tiene una probabilidad de malignidad del 0, pero es mayor a 0, pero menor o igual al 2%. Puede tratarse de un nódulo único o múltiple que tenga morfología ovalada o redondeada de márgenes circunscritos, que no presenta calcificaciones sospechosas, ni realce, o que presente realce tenue en una imagen recombinada. Las calcificaciones y las microcalcificaciones densas, puntiformes, que estén agrupadas en un grupo único que sea menor o igual de 5 milímetros en un área de 20 milímetros, una asimetría con realce que va a ser visible en una sola proyección, si tras el ultrasonido no hay correlato y se considera de baja sospecha, preferiblemente se consideraría biopsiar si hay duda, pero el seguimiento es una opción en casos pues muy seleccionados. En cuanto a los BIRADS 4, que va a ser el BIRADS que vamos a biopsiar, desde el BIRADS que vamos a empezar a biopsiar, hay algo sospechoso de malignidad y la probabilidad de malignidad va a ser mayor al 2%, pero menor al 95%. En esta categoría, o sea, en este tipo de estudios, la categoría 4 no la vamos a subdividir oficialmente como en A, B y C. Eso hay que tenerlo en cuenta. Entonces, que hay que pertenecer a la categoría BIRATS 4 en este estudio, las masas con nódulos ovalados, redondeados o lobulados, que puede ser una masa lobulada con márgenes indefinidos. Entonces, esto reemplaza, por ejemplo, el lobulado, como habíamos dicho antes, reemplaza el regular o microlobulado, ya no se dice. El realce tipo no masa puede ser de distribución focal, lineal, segmentaria, regional o difusa. No se usa ya múltiples regiones. El realce interno puede ser heterogéneo o agrupado. La asimetría focal con realce, sí, ya vamos a terminar. La simetría focal con realce, con morfología sospechosa, las clasificaciones amorfas, gruesas, heterogéneas o plomórficas finas, y la distorsión de la arquitectura sin antecedentes postquirúrgicos. Y el BIRAT5 es un hallazgo que es altamente sospechoso de malignidad, mayor o igual al 95%, que son nódulos o masas irregulares con márgenes espiculados independientemente si existe o no realce, con diferente intensidad de imagen recombinada, clasificaciones lineales finas o ramificadas, especialmente con distribución segmentaria, de si existe o no, independiente si existe o no realce, con diferente intensidad en la imagen recombinada. Realce tipo no masa de distribución segmentaria o lineal, siguiendo un conducto o hallazgos asociados como retracción de la piel o compromiso del pezón o de la piel. El BIRAT6 es malignidad confirmada, que pues ya se conoce por biopsia. Entonces, ya vamos a terminar. Este es un repaso rápido de los efectos adversos al medio de contraste que tenemos que tener en cuenta. Entonces puede tener se denomina reacción adversa al medio de contraste. Lo que hay que hacer es informar inmediatamente al radiólogo y hay que pues, ver el protocolo de manejo de reacciones adversas al medio de contraste que se utiliza en la institución. Puede ser extravasación del medio de contraste o pueden ser factores de riesgo para nefropatía inducida por el medio de contraste. Y bueno, ya para concluir, tenemos dos casitos rápidos en donde vemos, en este primer caso, no me les voy a preguntar por las dificultades técnicas que hay, pero vemos una mamografía digital normal en la que podemos ver una lesión en el cuadrante superexterno de la mama derecha, mientras que en su comparación con el lado contralateral no alcanzamos a ver. Entonces podemos describirlo como un nódulo especulado en el cuadrante superexterno de la mama, de la mama izquierda, que además de todo tiene microcalcificaciones en pero no sé si alcanzan a ver bien por la pantalla, pero está asociado a microcalcificaciones amorfas, que fue biopsiada positivo para proceso no formativo. Acá tenemos la imagen de ese realce nodular único, especulado, que no está circunscrito, de alta intensidad en el cuadrante superexterno de la mama izquierda, con las medidas, el volumen también hay que ponerlo, ya fue documentado para un proceso biopsiado, no se aprecian como hallazgos asociados, es decir, no se aprecia retracción del pezón ni engrosamiento de la piel. Se describe también en la distancia a la que está de la pared torácica, de la piel y del pezón. Tenemos que tener en cuenta pues, el tipo de tejido que tenga, pero vemos cómo se suprime en estas imágenes contrastadas el tejido de base y que podemos ver en las imágenes digitales y está realzando lo que presenta angiogénesis o neovascularización, como lo es la masa especulada sospechosa que ya se conocía. Acá tenemos otro caso de una mamografía digital convencional, que pues vemos en la mamografía cómo se ve la densidad mamaria, que es una densidad tipo B, vemos que no vemos hallazgos que sean sugestivos de malignidad, sin embargo sí se alcanza a visualizar una simetría en el cuadrante superior de la mama derecha, que no es representada en la proyección craneocaudal, y cuando se le hace la mamografía contrastada, vemos que efectivamente no hay ninguna lesión que nos sugiera angiogénesis o nos sugiera neovascularización, ya que todo el parénquima está realzando está realzando no hay ninguna lesión que realce más que parénquima, está homogénea en ambas mamas, por lo que es una mamografía con contraste negativa para malignidad. Listo, esta fue la bibliografía. Muchas gracias.
Buenas tardes, Sarita. Excelente exposición, muy completa, súper lindos los casos. Los comentarios después de la charla de la doctora Lung, pero me gustó mucho. De verdad que se notó el esfuerzo de hacer como el compendio de la revisión de este nuevo, digamos, modalidad que estamos nosotros ya haciendo en prepagada, pero pronto, si Dios quiere, la vamos a empezar a hacer acá también. Muchas gracias.
Perfecto, entonces ahorita me dicen, tenemos la profesora internacional, que me dicen que tienen problemas técnicos, entonces si les parece puedo irla presentando. Ya se conectó. Ah, estamos esperando que se conecte, ok. Bueno, mientras la doctora soluciona los problemas técnicos, vamos a presentarla. El día de hoy tenemos el placer de tener con nosotros a la doctora conferencista internacional Jessica Leung, profesora de radiología diagnóstica y jefe de imagenología mamaria en el MD Anderson Cancer Center en nuestro ciclo de imagen mamaria para los residentes de radiología. La doctora Jessica Leung es profesora de radiología diagnóstica en el Centro Oncológico MD Anderson de la Universidad de Texas y es jefa de la sección de imagenología mamaria. Es responsable de las operaciones clínicas, investigación y educación y desarrollo académico en su área. Se graduó con honores summa cum laude de la Universidad de Harvard y completó su formación médica y especialización en prestigiosas instituciones como Harvard y la Universidad de California en San Francisco, UCSF. Ha ocupado cargos académicos en reconocidos centros como Brigham and Women's Hospital, Dana-Farber y UCSF, y fue directora médica de un destacado Centro Integral de Mama en San Francisco. Cuenta con amplia participación en comités nacionales del Colegio Americano de Radiología, ha publicado numerosos trabajos científicos y ha recibido importantes reconocimientos, incluyendo el American Röntgen Ray Scholar y el premio de docencia destacada en esta universidad. El tema que vamos a tratar el día de hoy con ella es la actualización de BIRATS por ecografía. Ya vamos a esperar a que solucionen los problemas técnicos, pero le queremos agradecer por su experiencia y contribuir con la formación de nuestros residentes.
Hello, good afternoon, everybody. Can you hear me okay?
Hello, Dr. Jessica. Yes, we can hear you and see you.
Okay, perfect. Apologize for the delay. We had a little bit of IT challenge. Question for the group. How much time do we have? Do we have 20 minutes or 30 minutes? I understand you need to get back to clinic. So do we have 20 minutes, 25 minutes left approximately?
Yes, I think we have 25 or 30 minutes, whatever you need, doctor.
Okay, so we'll go aim for about 25 minutes of lecture, and then we'll aim for about 5 minutes of question and answer. Okay. All right. So on that note, thank you for having me here. Thank you for the opportunity. It's my pleasure and my privilege to be able to speak with you. And thank you for Dr. Ricardo for organizing this on behalf of your teaching group. So let me start by sharing my screen. Give me one moment. This is a new system for me. I'm used to other systems, so I'm trying to see how can I share my screen. Let me take a look at the share screen. Okay, I found it. Okay, so all right, I think we're good. Can you see my screen, everybody?
Yes.
All right. BIRADS v 2025 ultrasound. Everybody see that?
Yes.
Okay, perfect. So next 25 minutes or so, we're going to talk about BIRADS v 2025 ultrasound. And I'm Jessica Leung. I'm a radiologist at the MD Anderson Cancer Center in Houston. And thank you to my colleague and friend, Dr. Ricardo, for organizing this and for allowing us, Dr. Ricardo Rodriguez, for organizing this and for always caring about teaching and our residents. All right, so on that note, thank you, residents, for all that you do. So BIRADS, what is it? Well, it is essentially a standardized language that is used to communicate, which in turn provides guidance for image interpretation and assessment, allowing for improved patient care. Okay, so BIRADS is, of course, breast imaging reporting and data system. That's what BIRADS stands for, and standardized, so that we all speaking a common language and can understand each other. It is language that we communicate with each other. Radiologists in breast imaging communicate with other radiologists outside of breast imaging, compare with our clinical colleagues, primary care doctors, OBGYNs, surgeons, pathologists, etc. And also many times now communicate some ways with our patients, as patients, at least in the United States, have increased access and interest in reading their reports. Okay, now this in turn allows guidance and helps us, breast radiologists, to do our job. And our job is to interpret the image, but also assess the clinical significance of the image, all of which allows for improved patient care, the ultimate goal of what we do with really everything, and in particular, in this scenario, BIRADS. Okay, why the words matter? We know that the choice of words is important in terms of communicating thoughts, communicating intent, communicating the desired result. Okay, so words matter. Words matter in real life to bridge different groups to connect, to reach out, to serve, to team with, etc. Okay, but also words matter in terms of BI-RADS for medical care, and oftentimes using BI-RADS will help us do our job and also provides a foundation for avoiding mistakes that may result in, at least in the United States, sometimes medical legal consequences. Okay, so this is the book. Okay, BI-RADS. We celebrate the publication, which happened in RSNA in 2025, which was December 1st, was the exact date. And that's BI-RADS v 2025 manual. A few things about that. This is the product of the American College of Radiology. Okay, these are the colors of the ACR, American College of Radiology currently. I know ACR also stands for Association of Colombian Radiologists, which I know is a little different. So ACR in the setting that I'm discussing is American College of Radiology for the rest of this lecture. And here's BI-RADS. Notice that it's called V 2025. The V stands for version. Okay, and in the past, BI-RADS has been the various numbered editions, meaning like 4th edition, 5th edition, etc. And all along, we were talking about this as potential 6th edition. However, it was changed to V 2025 because, as you may know, in ACR now, there's many kind of RADs. Okay, there's TI-RADS for prostate, TI-RADS for thyroid, etc., etc. And all those use the version and the date. So in order to be consistent, to be standardized, instead of calling this the 6th edition, it is called V 2025. And notice that there is also called a little bit different here is the manual. So instead of the lexicon and atlas, which is what it was before, lexicon being words, atlas being images or pictures, okay, it is now called manual. And the reason of the thought is that there's a lot of management behind it now. So it's not just, it is words, it is images, but all tying all that together is the fact that there's management involved. Okay, so I'm only going to talk about the ultrasound in the remaining time I have. Note that there are several sections to BI-RADS v 2025. There is the mammography, there is ultrasound, there is MRI, and there's a new component on contrast enhanced mammography. That's the 4th one. And then the 5th one is on audit and outcomes monitoring. Okay, so 5, and they are mammography, ultrasound, MRI, contrast enhanced mammography, and audit and outcomes monitoring. For the purpose of today, this afternoon, I'm only going to focus on the ultrasound, the 2nd of the 5 sections. So on that note, here we are, ultrasound. Okay, so ultrasound, I'm going to give you a very sort of overview look, from high up in terms of the organization. So for ultrasound, there are several components. I'm going to tell you about each of them in turn. Number 1, tissue composition. Number 2, masses. Number 3, non-mass lesions. Number 4, calcifications. Number 5, associated features, and I'll go into a little bit of detail what that means. Number 6, special cases. I won't have time to talk about the details of that, but let me suffice it to say that cysts are included in the special cases component. Okay, of course, ultrasound is amazing for looking at cysts, and of course, cysts are common. So that's an important consideration for you residents to take away. Of course, there are all kinds of cysts. There's simple cysts, there's complicated cysts, there's cluster microcysts, etc. They all fall under the special cases situation. Again, we won't have time to go into details of that, but know that they fall into the category of special cysts. And then lastly, lymph nodes. Okay, so these big components in the section of ultrasound, which is one of the 5 sections of BI-RADS v 2025. So again, tissue composition, masses, non-mass lesions, calcifications, associated features, special cases, including cysts, which include cysts, and then lymph nodes. Okay, so start out with tissue compositions. Oh, and I put this on here to show you that of everything, I'm going to focus on masses and non-mass lesions the most, because these are the primary manifestations of cancer at ultrasound, is masses or non-mass lesions. But I'm going to start talking a little bit about tissue composition. Not because that's the biggest area of breast ultrasound, but because that's sort of a interesting research area. And of course, breast density in general is a big area of interest, and mammography, as you know, right? So in the United States, there is now a federal law mandating that we tell our patients in layman's term, in patient language, the breast density, okay? So, and as you know, at MRI, there is the density, there's the breast composition, but there's also background enhancement, 2 components. And at ultrasound, for the first time now, there are 2 components to what we call breast composition. So first, there's the tissue pattern, and there's the glandular tissue component, GTC. And this GTC is the new element, not present in the 5th edition or the 4th edition, but only in V 2025 for the first time. So again, whereas mammography only has one thing, which is the breast density, now on ultrasound, we have 2 things, and those things are tissue pattern and GTC, glandular tissue component. Now, tissue pattern, these are similar, or these are actually the same as the BI-RADS 5th edition, which is homogeneous background ecotexture fat, homogeneous background ecotexture fibroglandular, and heterogeneous background ecotexture. These are the various tissue component potentials at breast ultrasound. The new part is the GTC. And let me tell you what GTC is, glandular tissue component, based largely on research results from our colleagues in Asia and Korea. This is in 2021 in the journal Radiology. So allow me to explain what GTC is. So if you think of this as sort of the histology of breast tissue, anteriorly on the top here, you have things like skin, Cooper ligaments, subcutaneous fat, premammary fascia. And the back or the posterior aspects of the breast, you have mammary fascia, retromammary fat, pectoralis muscle, etc. But this here, the middle, is where the action is, if you will, for cancer formation. So obviously, we care a lot about that as radiologists. And in this, which is called the mammary zone or the fibroglandular tissue zone, you have basically lobules and terminal ducts. Some of us call these TDLUs, terminal ductal lobular units. Okay, that's shown in gray. And what's shown in white is the interlobular stroma, the connective tissue between the TDLUs. And cancer forms in this area. Cancer doesn't form in the skin or the Cooper ligaments or the fat per se, but in this area, which is the mammary zone. Okay, so it turns out ultrasound that the interlobular stroma, the connective tissue, looks relatively white or hyperechoic or echogenic. And it turns out that the terminal ductal lobular units look relatively dark or hypoechoic. Okay, so using that principle, you can kind of visually assess and determine the tissue, the glandular tissue component, and the nomenclature proposed in V 2025 by RADS is minimal, mild, moderate, and marked, which is analogous to what is used for background enhancement at MRI and a contrast enhanced mammography. So marked, assessment is more dark components than echogenic components, more ducts, more lobules than stroma. Stroma is less, okay? The connective tissue is less. As opposed to minimal, it's more echogenic, more white, brighter, because you have more stroma, okay? And here it is. FGT is fibroglandular tissue, all right? So you're looking at this. This is minimal, less than 25%. That's a visual assessment. Less than 25% is the ducts and the lobules, versus marked is equal to or greater than 75%. More of the darker hypoechoic terminal ductal lobular units compared with the echogenic stroma. Okay, so that's the difference. So just a visual assessment. And interestingly, aside from ability to find cancers or not, is the fact that high GTC shows little or no lobular involution at histology, and that's associated with a higher risk of breast cancer. So you can imagine the clinical implications of such assessment. Now, how it's going to play out in the clinical such situations, we'll see. V 2025 is new, GTC is new, and we'll see, hopefully see reports coming out in upcoming years. Now, of course, we talked about the fact that this is from Asia, and there's already been research on this subject. And this subject, this is a very recent article, January 2026, just last month. And this group looked at recurrence-free survival of patients with early stage breast cancer. So these are not screening patients, as opposed to this study here is a screening study. But here, this is patients who have early stage cancer. So what was done was that this was automated breast ultrasound and not handheld, because other studies are done with handheld. But the point is that when they look at GTC right here, the high GTC was statistically associated with worse recurrent-free survival. Okay, so in other words, you can kind of think about maybe high GT is associated with higher risk, worse recurrence-free survival. That means they did less well, okay, because they recurred more, if you will. Okay, so again, not so much the exact one study or one concept, but the overall concept I want to convey to you is the GTC and relevance in clinical work that we do in breast imaging. Okay, so more to come, hopefully in the very near future. So I'm going to leave tissue compositions now and go on to a second area, which is masses. Okay, and for the sake of time, we're not going to look at each of these in great detail, but know that there are 5 characteristics you want to think about when you assess a mass at ultrasound, and they are shape, orientation, margin, echo pattern, and posterior features. And these are the same as the 5th edition. What is different is what I've shown here in pink. Okay, so the words are a little bit different. So shape before was oval, round, irregular. Now we've added the word lobulated in there to show a shape. Okay, that's kind of between oval and round. Orientation, you know, it was not parallel, was the language before, but now we'll change it to non-parallel. Okay, so it's parallel and non-parallel. I know many of us will say taller than wide, but taller than wide is actually not a BI-RADS term. The term was not parallel before, and now is non-parallel. And the margin, you have circumscribed or not non-circumscribed. Again, the former term was not circumscribed. We changed it to non-circumscribed. And of the non-circumscribed options, you have indistinct, microlobulated, angular, and spiculated. Now, I should also point out the fact that in V2025, all of it, not just ultrasound, but mammography and MRI and contrast-enhanced mammography, the listing, the ordering is going from the least suspicious to the most suspicious. So for example, under shape, oval is the least suspicious shape and irregular is the most suspicious shape, okay? And of these terms here, like for margin, that's non-circumscribed, the least suspicious of these 4 terms is indistinct and the most suspicious is speculated. Okay, now that's not always possible, and that's not always possible. We don't always have data for everything, but whenever possible, that was done. Okay, from the least suspicious to the most suspicious, not just ultrasound, but also mammography, also MRI, also contrast-enhanced mammography. Okay, so allow me to also say that for echo pattern, there was a term that was complex, cystic, and solid. That's the old term, crossed out, no longer. That was the 5th edition, but instead we're calling it mixed, solid, and cystic. Complex, you know, we thought it may mean different things to different people, and we also mixed is just basic, simple. You know, that's what it is. It's a combination. It's mixed. Okay, so and we thought we'd bring up the word solid first because that's usually the more important component clinically, because that's the component that may be cancer. Okay, and a little bit of change, instead of mixed posterior features like shadowing and enhancement in the past, we just have any shadowing is now considering shadowing. So the word mixed and mixed posterior features is no longer there. All right, so a quick overview. So let's look at a case, and this is a case of mammograms, MLO and CC. What you see here, anteriorly yellow is a mass on mammography, and this mass is palpable, but I'll tell you this mass has been stable for a number of years. I know it's difficult to see on projection, but there are coarse calcifications that are stable. I'm kind of thinking fibroadenoma, okay, based on oval, circumscribed margins, stable for years. But this mass is the new mass posteriorly in the upper outer posterior breast. You can even kind of see here that the margins, oh, maybe not circumscribed. And of course, we go to ultrasound, and here are the ultrasound correlates. In the yellow, the anterior mass, orientation, you know, parallel, margin, oval. Shape is oval, margin circumscribed. Of course, this is a classic fibroadenoma. But in contrast, the posterior mass looks like this. The shape, maybe some of you may say round, maybe some of you may say, you know, irregular. Margin, not circumscribed, right? Maybe angular, maybe, you know, I guess you can even say speculated, you know, here, depends on your perspective, or indistinct. But bottom line is that the red box mass, which is posterior, compared with the yellow, gives you quite a different sense. It guides your assessment, guides your management. This one I'm going to biopsy for sure. the one on the upper left-hand corner. Okay, and just for completeness, ultrasound found additional masses in this patient, not necessarily appreciated on mammography. And here on the bottom left, you have what's a good representation of a lobulated mass in terms of shape, parallel orientation, just to talk about some of the features. And here, I think you have an oval mass, also parallel in orientation. And in terms of diagnosis, fibroadenoma, fibroadenoma, fibroadenoma. These three here. And then one on the top left corner is an invasive ductal carcinoma, as you kind of suspected based on mammography. Okay, another case. Okay, so let's say this is a palpable lump. What are we thinking about this? Mass at ultrasound is a mass, right? So ecotexture is what I try to convey here. And this is a decent example of what we call a mixed solid and cystic mass. Okay, here's the cystic parts. The solid parts demonstrate to be solid based on a Doppler interrogation. And a pathology, a very classic, if this is a cancer, it is a triple negative breast cancer. And just to show the rest of it, here it is on CT. The cystic part, non-attenuating, non-enhancing, low attenuation. And here's the MRI. Again, the cystic part is here, non-enhancing. And here's the mammography with the clip. Okay, triple negative breast cancer, mixed solid and cystic, using BI-RADS language at ultrasound. All right, moving on. Given the current advances in ultrasound equipment, capabilities, and knowledge of breast ultrasound, there is increasing awareness and identification of abnormalities at ultrasound that do not rise to the criteria of a mass. So you're talking about something based on our current knowledge, current equipment, and capability. That's something's wrong, and maybe a cancer. I shouldn't say something's wrong. Something is there. That's a lesion, not just tissue. But it may be a cancer, it may not be, but it's something there, but it's not quite a mass. And that's what we call a non-mass lesion. And this is a brand new thing in BI-RADS. Okay, it's not a brand new concept. There's literature, publications on this, but it's brand new in terms of BI-RADS. So let's look at what a mass is. A mass is a space-occupying finding seen in at least two different imaging planes, while a non-mass lesion is a sonographic finding that is identified in at least two imaging planes, but lacks the three-dimensionality or conspicuity of a mass, such as characterizable margin and shape. Right? Remember, there were 5 characteristics of a mass, and they were margin, shape, orientation, posterior features, and ecotexture. Well, we don't have all that in non-mass lesion. And in particular, we don't have margin or shape, which are very key in a mass. We don't have that in a non-mass lesion, which is one of the reasons why it's a non-mass lesion instead of a mass. Okay. Many of you like to travel. I like to travel. I love visiting Colombia, and I had the privilege to do that a few times now. Beautiful country, of course. And here you have luggage, that we store on top like this, kind of flat. This is the older planes, kind of like pancakes. But newer planes is on the side, so you can store more luggage like this. And I kind of think about that like a taco. And I'm sure you have great access to taco in Colombia. Of course, it's a classic food in Texas where I live. So a non-mass lesion is less like an apple or a mass and more like a pancake or a taco, versus a mass is more like an apple or an orange, like the mass. Okay, and I love food. And on a recent thinking about Europe, this is a strudel that we see in Europe. That's kind of like a non-mass lesion, okay, kind of flat like this. You can put it like a taco or like a pancake, depends on the plane. Of course, in Colombia, I'm thinking like an arepa, maybe, if I pronounce it correctly, another food that's kind of flat, that can look like this, okay, non-mass lesion. All right, enough about food. Okay, so non-mass lesions, often subtle and detected only because of the disruption of background tissue. While it's identifiable in 2 planes, it may be visualized primarily in 1 plane only. Size determination can be difficult, and often is difficult because it lacks definitive shape or margin. Now, segmental distribution has been found to be highly predictive of malignancy based on data. And while the most common invasive cancer by far is still ductal carcinoma, but the histologies of invasive lobular and also in situ cancer, that is ductal carcinoma in situ, DCIS, is disproportionately high when it comes to non-mass lesions compared with masses. All right, non-mass lesion, remember it's simpler, okay? And these are the 3 characteristics you should look for: distribution, echo pattern, and posterior features. So it's a lot simpler than the masses. And even notice like within echo pattern, the words are less, meaning we don't have like isoechoic. We don't have mixed solid and cystic that we do have for masses. And one of the reasons for that is because non-mass lesion is a new entity. We want it to be conservative. We want to start out with less. We want to start out with whatever we have in terms of available data currently as much as possible. So hopefully as this is introduced now in V2025 BI-RADS, we'll have a lot more, publications, research on this topic, and maybe this will grow and build on it, okay? So we want it to be conservative and start out with what we know as opposed to sort of assuming, certain characteristics. So what we do know, though, is distribution is really, 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 really key. So think about this distribution like the distribution of non-mass enhancement in MRI and at contrast enhanced mammography. Think of distribution almost like the distribution of calcifications at mammography, right? You know how in mammography for calcifications you have morphology and you have distribution? Well, think as though distribution. And remember, in BI-RADS V2025, we're going from least suspicious to most suspicious. So regional is the least suspicious, segmental is most suspicious. And for sure, that segmental distribution is assigned to you that, oh, I'm worried about a cancer. Okay, so that's the one thing that's really established in the literature. Segmental distribution, non-mass lesion is bad because it is a predictive sign of breast cancer. Okay, let's look at a case. Okay, here's a case, and you can see that these are calcifications. So when it comes to calcifications, we want to look at morphology, we want to look at distribution. And this patient also, by the way, had a palpable lump that were the calcifications, and here's one of the annotations, the markers for it. And here we have segmental distribution, pleomorphic morphology, calcifications, palpable lump. Lateral on the left, CC on your right, you kind of feel suspicious, right? Probably biopsy. Yes, you can go to stereotaxis biopsy, but what if we try to look for ultrasound first? Because of course, whenever you do ultrasound, you find it under ultrasound, you can biopsy under ultrasound, which for the most part is the approach preferred for a variety of reasons. Okay, so here we are, ultrasound of the palpable lump. Okay, fairly large area. This is meant to show you the nipple. You can kind of see it extending to the nipple, if you will. So there's something here, but it's not quite a mass, right? So we have a word for that now, and that word is a non-mass lesion. Okay, so this is a non-mass lesion in ultrasound that correlates with the presentation of palpable lump and with the ultrasound finding, mammography finding of those segmental pleomorphic calcifications. And there could be associated features like posterior shadowing, like an echogenic line, just like you have for a mass. Having these features increases the probability of malignancy. Here you have these little echogenic foci, which are calcifications, microcalcifications, and I'm going to talk about that in just a little bit, micro versus macro. And then here you have vascularity. Okay, all this increases the probability of malignancy. And indeed, this was a case of cancer. It was actually DCIS, ductal carcinoma in situ. All right, another case. Okay, this patient had a palpable lump. Here's the marker, upper, inner, posterior breast. And especially when you compare with prior studies, you can see that there is something here's a little bit different from the other side. We call that a focal asymmetry. So that's a palpable lump, focal asymmetry, and mammography. We'll get into ultrasound of this finding, the lump and the mammographic focal asymmetry, and this is what we found. So again, something, that's not completely normal. It's not just tissue, but I can tell you that on the transverse planes, it really looked quite different. So it looked very different in the two imaging planes. We just didn't quite feel that it is a mass. Here it is showing the vascularity along this longitudinal plane. And we biopsy this under, we call this a non-mass lesion. We biopsy that under ultrasound. And here's the biopsy clip. See the biopsy clip there in red, upper, inner, posterior breast. That's the biopsy clip. And this proves to me that the ultrasound finding that we had and the mammographic finding, which matches the palpable lump, they're all one and the same, right? Because look, the clip is where we expect it to be, okay? And here is the MRI to further continue the evaluation. And here's the MRI enhancement in the sagittal plane and in the axial plane, upper, inner, relatively posterior breast. So non-mass enhancement MRI, the spectrum of findings that we're seeing across modalities and pathology, this was a case of, here's the answer, 3 centimeters of DCIS. There were microinvasive, invasive ductal carcinoma involved, but majority of the finding 3 centimeters of it was ductal carcinoma in situ. So I think what we're seeing here at MRI, what we saw at ultrasound, at mammography, actually is the DCIS part, okay? So another case of non-mass lesion, DCIS as the histology. All right, moving on from non-mass lesions now, quickly on the remaining components of the BI-RADS ultrasound section is calcifications. Here you have on your left the 5th edition, on your right V2025, aka 6th edition. You notice that we have micro versus macro calcifications now. And of course, your best modality for assessing calcifications remains mammography, not ultrasound, okay? Given I said that, you know, we have better and better technology now in terms of the equipment and your knowledge, our knowledge of breast ultrasound. So you can often say, this is a microcalcification or a macrocalcification. Macrocalcifications are, of course, larger, as the name suggests, and gives you shadowing many times, and of course, suggest benign, versus a micro, like the case I showed a little bit earlier, you know, with the segmental pleomorphic calcifications, those look like little echogenic foci. Okay, all right, you have calcifications in a mass or non-mass lesion or outside, and you have intraductal calcifications. So 5th edition and V2025. Moving on, associated features. Here they are, okay? Of course, they're in your BI-RADS manual itself. We won't go into details on any of them, really, but suffice it to say that the pink is what's changed from, or well, let's focus on that. And the new one is the echogenic rind. Okay, the echogenic rind is a new word, if you will, new lexicon term. And let me explain the echogenic rind, the difference between that and the echogenic pseudocapsule. So this is an echogenic pseudocapsule. It's suggests benign, usually is sharp and uniform, and is thin like this little white line around, oval mass usually, classic fibroadenoma. Versus an echogenic rind is suggests malignancy. Is fuzzier, indistinct, thicker, and more variable in thickness. Like this area is thicker than this area, and the shape of the mass that it surrounds, that it can be any shape, doesn't have to be oval. Okay, and this is, of course, the classic invasive ductal carcinoma, right? Not parallel, non-parallel, et cetera, et cetera. Okay. Now, you want to include this as part of the overall measurement, because that's been shown to correlate best with pathology. Let's look at another example, a case. So 2D images in the middle, your tomosynthesis slices on the outside. So here in the upper, slightly inner, aspect, maybe a little bit central, is a small mass. And you can see that, of course, on the tomo. Maybe you can see the shape of the margin even better. And of course, we see that best in the spot tomosynthesis images. Here and here. Okay, so you're worried because I think I see spicules. So what are you going to do next? Of course, is ultrasound. And here's where you find an ultrasound. A small mass, but small could still mean cancer, of course. And of course, our goal is to find small cancers. But what I'm trying to show you here is this. You see that? That's your echogenic rind. Indistinct, the mass is not necessarily oval. It could be any shape. This area is thicker than this area, so variable. And of course, I think you're feeling that this is a cancer. And indeed, it was a 7mm invasive ductal carcinoma grade 2. And this is, again, there's literature behind all this. And this is a very, very recent literature published in a PubMed indexed in December 2025 from our colleagues at Duke University, where they looked at this feature of echogenic rind, and they found the following. It is more specific than sensitive as a sign. It is usually characterizing invasive cancers that are luminal A subtype, and it decreases the extent of disease size underestimation when you include it, which is another way of saying you want to include that echogenic part in your overall measurements because that correlates best with pathology. Okay, and I'm going to show you this next, which is a commentary in HAR in December 2025. Show you some of the, how BI-RADS is a living, breathing document. It changes, depends on data and of course on understandings and on concepts. Okay, so here are some investigators who believe that the rind is not the most appropriate term, and the feedback is that the peripheral echogenic zone may be a better term, and that is not a rind. Okay, that was the title of the article. Peripheral echogenic zone is not a rind. So, and this is really the current accepted term is echogenic rind, but this will show you that BI-RADS is a living and breathing document. We appreciate and look forward to your experiences in Colombia and your feedback. All right. So lastly, lymph nodes. This area expanded a lot in BI-RADS, in particular mammography, in particular ultrasound and MRI, okay? A little bit in mammography as well, but of course, as you know, mammography cannot really look at the lymph nodes the way that ultrasound and MRI can, especially ultrasound, I'm gonna say, because it can look at all the regional nodal basins. So here we are, the histology of a lymph node, just, the rough anatomy histology of what a lymph node looks like here, okay? You have afferent lymphatic channels, and you can imagine tumor going in here and gets trapped in the cortex or the peripheral zone by these follicles made of lymphocytes. That will result in a change of the morphology and changes in what you see at imaging, ultrasound and MRI in particular. And a lot of our discussions based on the AJCC, American Joint Committee on Cancer Staging Manual on breast cancer. Of course, what we're talking about is the TNM staging, in particular the N part of TNM, anatomic staging. And these are the regional nodal basins that are involved in breast cancer. So these are lymph nodes that are outside the breast, but they are not considered metastatic disease. Okay, they're not, meaning they're not M1 disease, and they remain they're in the N part and not M1 disease, because M1 by definition is stage 4, as you know, which is poor prognosis, but these are still considered local regional disease. Even though it's outside the breast, okay? And yes, you have lymph nodes inside the breast, that's the intramammary node, but in terms of outside the breast, you have the axilla, which is here, okay? And the axilla is divided into 3 levels, and pectoralis minor muscle, which is this muscle here, is the landmark that distinguishes the 3 levels of the axilla. You have level 1, lateral to the lateral margin of the pectoralis minor muscle, level 2, between the the lateral and the medial margin of the pectoralis minor muscle, shown here in the color red. And then you have your level 3, which are medial to the medial margin of the pectoralis minor muscle, shown in the color yellow. You have your internal mammary chain, and you have your supraclavicular nodes, defined as the clavicle, internal jugular vein, and the omohyoid muscle. That triangle that makes, that's the supraclavicular region. Okay, so these are your regional nodes that are not yet M1 disease. And you can image them all with ultrasound. And here we are with ultrasound. What you have here is ribs and internal mammary node. You have here supraclavicular node abnormal looking, and you have here just an X-line node. But as in one of the first areas we look at. I don't mean just as a not significance, because it is, but I mean just in the sense that it is, very basic part of breast ultrasound. And the morphology is abnormal, it's thicker here in terms 3 millimeters, the approximate cutoff we have. And of course, there's displacement compression of this, which is the echogenic hilum. It's also abnormal. So all 3 of these nodes are involved with breast cancer. Okay, so that's discussed in BI-RADS v 2025. So along that note, I want to say thank you very much for this time we have together. Muchas gracias. Please help me with my Spanish. My email and my social media handle, and here is MD Anderson. And should you ever be in my neck of the woods, let me know. We'll have like a nice Tex-Mex food together. Okay, thank you.
Thank you very much, Dr. Jessica, for the great conference. Always, Colombian people love you always. Okay, see you soon in Medellin, in another place. But for name of the residents, I would like to say thank you for participation in this course.
Thank you. Thank you. I don't know we have any time. I have a few minutes. If you have, would like to ask me any questions, but I know that you may have to go back to clinic, so I'll leave that to you.
Okay, I appreciate it. I have a question. Is one question to somebody say me, a colleague, what is the situation for the notes when the patient get a training in the chemotherapy adjunct? What's the meaning for what's happening in the node when the people got treatment with the neoadjuvant treatment?
Okay, I'm not sure I heard the whole question, but I'm going to repeat it. I think I heard it. The question is, what BI-RADS assessment would you give for lymph nodes that are undergoing neoadjuvant therapy? Is that the question?
Yes, and what is the answer after treatment?
Okay. Again, I'll try to answer what I heard and correct me if I'm not understanding the question appropriately. Okay. So basically, how to assess a lymph node ultrasound is a whole different lecture, right? Which, is not the topic today and we don't have time to go into now. But basically, you learn what's abnormal looking. So let's say I have a patient with, let's say I see an abnormal lymph node ultrasound. You can call it a BI-RADS4, recommended biopsy, okay? And let's say you biopsy it, and it is cancer. Then that becomes, a BI-RADS6 case, if you will. And the patient undergoes neoadjuvant therapy, and that abnormal looking node is now normal looking. But even though it's normal looking, the patient has not had the definitive treatment. So likely that patient is still a BI-RADS6 kind of case, because there may be microscopic disease and she hasn't had the definitive treatment, which is surgery for the most part in most of our practices. Okay, that's for sure the application of the BI-RADS assessment in the breast lesions. It gets a little complicated with the lymph nodes. And if you have a specific case, please feel free to email me, but that's the general idea. If the question is, how do we know when there's a neoadjuvant therapy lymph node is responding or not? Well, because of the change in morphology back to what's a normal looking node and the decrease in size. But ultimately, of course, is patient will likely have some sort of surgery on the axilla.
Thank you very much. Thank you, Dr. Jessica.
All right. Well, thank you, everybody. And Dr. Rodriguez, Ricardo, you know how to find me if there are additional questions. Anybody else right now?
Okay, thank you. Thank you, Dr. Jessica. Okay, bye-bye.
I love it. Hello, everybody.
I appreciate it. Thank you very much. Bye-bye.
All right, take care. Bye-bye.